Hi, my name is Anisha. Welcome to another episode of The Heart of the Matter. I'm joined by Bourann and Ankit. Today we're going to talk about the Kraken study, which is testing oral Muvalaplin for lowering lipoprotein A. So, lipoprotein A, or LP little a, is an LDL with ApoA covalently bound to ApoB, which is what makes it structurally different from the other LDL or low density lipoprotein in our body. So, it is an independent risk factor for atherosclerotic cardiovascular disease and calcific valvular aortic stenosis. So, while LDL is much more abundant than LP little a and still remains the biggest contributor to atherosclerotic disease, or the risk of it. LP little a is 6 times more likely to be atherogenic than LDL on a per particle basis. And LP little a, in addition to being atherogenic, is also thrombogenic and has pro-inflammatory properties. So for a long time, LP little a has been linked to higher risk of cardiovascular disease, particularly heart attack and stroke. But these LP little a values, what's interesting about them and what's different from LDL significantly is that it's genetically determined. They have little to no influence from the environment or lifestyle factors, and adult levels are reached in childhood, even typically by 5 years of age. So lifestyle modifications don't really seem to have appreciable effects on reducing LP little a. Medication is the only way to reduce it. So there's no medications on the market right now that have a substantial LP little a reduction. The closest ones we do currently have are PCSK9 inhibitors, which can reduce the level about 20 to 30%. And then the additional part of it is that there's no general consensus as to what a high LP little a level is, or there's no standard cutoff is what I meant to say, but there is a general consensus by ACC, AHA, the Canadian Cardiovascular Society, the European Atherogenic Society or Atherosclerotic Society, and the National Lipid Association. And that is greater than or equal to 50 milligrams per deciliter, or around 100 to 125 nanomoles per liter. So the thing is that Muvalaplin, it inhibits lipoprotein A formation, and a 14-day phase 1 study demonstrated that Muvalaplin was well tolerated and reduced lipoprotein A levels up to 16%. So Bourann is going to talk a little bit more about the methods of this study.
Yes. So after the phase 1 trial, we moved on to the phase 2, which is what the Kraken study is specifically discussing. And so this was randomized, double-blinded, and placebo-controlled trial. This was over 5 different continents at 43 different centers. And it did include 233 patients. So not large, but a broad spectrum of patients across the world. The criteria to be eligible for the Muvalaplin was adults aged 40 or higher who were at high risk for cardiovascular events, which they determined either based on a history of cardiovascular disease, peripheral artery disease, ischemic stroke, or patients who had familial hypercholesterolemia. And then they had to have a lipoprotein A concentration of above 175 nanomoles per liter. So this is somewhat substantially above the accepted cutoffs for elevated lipoprotein A, which is nice because we know that these people across many societies are deemed to have high LP little a levels, and therefore would maybe be the people who would benefit the most from this type of trial. And so the way it was randomized was to a placebo group and then 3 doses of Muvalaplin. So there was a low dose group that was 10 milligrams a day, a mid-range dose that was 60 milligrams a day, and then the highest dosage was at 240 milligrams a day. And again, this is an oral medication, which we'll talk about that a little bit later. which is something that makes it unique. And so these patients took the Muvalaplin for 12 weeks, and their LP little a levels were measured prior to the administration of this medication and then again at 12 weeks. And so they then, at the end of the 12 weeks, measured both intact lipoprotein A and then this traditional apolipoprotein A assay, which are two different ways to measure apolipoprotein A, which Ankit will talk a little bit more about because that is something that can affect our findings. And so at the end of 12 weeks, there was a significant reduction in LP little a levels in all doses of the Muvalaplin group, but there was sort of a dose-dependent response. And so in the 10 milligram group, we had a 47.7% reduction in LP little a. In the 60 milligram group, we had an 81.6% reduction. And then in the highest dose, which was 240 milligrams a day, we had an 85.7% reduction, which is pretty significant. So we can kind of see that it does drop off somewhat, somewhere between 60 and 240 milligrams, but there is a dose-dependent response. And this was the primary outcome, was the change in LP little a concentrations. Now, there were a couple of secondary outcomes that were investigated. For example, apolipoprotein B levels were also assessed, and there was similarly a dose-dependent reduction, although not quite as significant. So it was 8.9%, 13.1%, and 16.1%. Now, the aim of this medication was not to reduce apolipoprotein B levels, but something that, you know, we can kind of look at and evaluate. And then the last thing that was a secondary endpoint was changes in high sensitivity CRP levels, which we've sort of used at times to risk stratify patients. And there was no change in those levels between placebo and the Muvalaplin. And then the last thing to note is that patients generally tolerated the medication well, and there were very few reports of side effects. So then going from these results, we can kind of talk about what this means and what the next steps are to evaluate Muvalaplin. And Ankit will start talking about that.
Yeah, so you guys brought up a lot of important points about the study. So I just want to touch base on a couple of things that we all found interesting. So one of the first things was the assay that they use in this study. So generally, the traditional assays that evaluate lipoprotein A levels use apolipoprotein A as a surrogate marker to measure lipoprotein A, since it's a component of it, right? But in this case, since we have Muvalaplin, which is an inhibitor and inhibits that non-covalent bonds between apolipoprotein A and apolipoprotein B, that would overestimate the amount of lipoprotein A you would have in your body. So what this study did was that they used a sandwich assay. Basically, is they measured the amount of apolipoprotein A and apolipoprotein B that were together, and that's how they got the intact lipoprotein A levels. The next thing I wanted to touch on was something Anisha mentioned, which is lipoprotein A has multiple functions, not only prothrombotic, it's pro-atherogenic and also pro-inflammatory. We thought that the prothrombotic one is the most interesting because lipoprotein A has a very similar molecular structure to plasminogen, and as we know, plasminogen is involved in the coagulation cascade. So if we're inhibiting some of the thrombolysis, we're going to have a prothrombotic state. The other thing that Bourann touched on a little bit was that we also found that there were reductions in LDL as well. Obviously not as much as the lipoprotein A levels, but there were modest reductions between like 10 to 20%. And then the study did not find any reductions in CRP, so there was no reduction in the pro-inflammatory state of atherosclerosis or coronary disease in general. The other thing that we found interesting is that lipoprotein A particles contribute to atherogenicity by also carrying oxidized phospholipids, which are important in the development of atherosclerosis, and then also in calcific aortic stenosis and stuff like that as well. And then talking about how we apply these findings and some of these studies, as Anisha mentioned, there's not a really good consensus about levels and what we should do with lipoprotein A levels in general. Some people say we should just screen it once in our lifetime. Some people say we should screen it in patients with a lot of history of premature ASCVD or family history of premature ASCVD, so there's no great consensus. And the other question that brings up is how much do we actually reduce? They've done like genetic epidemiology studies that show you have to have pretty large reductions in lipoprotein A levels from 85 to 250 nanomoles per liter to lower cardiovascular risk. So that's a significant amount. And this study did at the medium to high doses reduce it almost 80%. So that's interesting. And then the other thing is how do we apply it across the board? Because I mean, medications can't be applied across the board. Our populations are very different from each other. So how does it apply to ethnic and racial groups like African Americans and South Asians have a higher cardiovascular risk? Um, and then lastly, a couple more things. Since this study did not show any anti-inflammatory risk, do we use Muvalaplin and statins together to target some of the other components of the development of atherosclerosis? And then lastly, some of the trials that will be coming out in the future are evaluating reducing lipoprotein A levels, but specifically targeting transcription. So Muvalaplin, the advantage of that's oral, and then number two, it's inhibiting the assembly of lipoprotein A, but these would just prevent it from being transcribed altogether. So I think that's interesting. Do you guys have any other final thoughts?
I think it's exciting that we found an oral medication that has some substantial reduction in LP little a. I think what comes next is that we have to determine if reducing it significantly actually affects cardiovascular outcomes in our patients. And so I think that's the next step in this study. But, you know, while it's exciting that it does lower it, we know there's an association that may not necessarily confer a benefit if we do reduce it in patients who are elevated at baseline. So I think that will be interesting to see. I think that it's an oral agent is exciting from the standpoint of accessibility and ease of use, since most of these other agents, like you were saying, are injectables. The mechanism is very different than the mechanisms of these other drugs in the pipeline. So it's just interesting that, you know, there's been a lot of innovation in the field of hyperlipidemia. And so I think it's exciting. I guess we have yet to see the impact of it, but those are my thoughts. What do you think, Anisha?
Yeah, I think mine are, I obviously agree with everything that you're saying. I was thinking more also about when do we screen for lipoprotein little a? Because obviously now we know that it's genetic. It's something that, you know, is established by the time you're 5. So if it is positive, what does that mean for further testing? You know, because is that going to cause like unnecessary investigation in our patients if we do screen for it earlier? You know, what if we're screening a 12-year-old and there's a high value? Are we going to see how this has impacted their arteries at baseline? And then what happens when we screen at 50 and it's almost, we only screen because they had a major cardiac event? How's that? I mean, yes, that will prevent the future, but are we going to be able to prevent cardiac events? So that's the thing that I'm thinking. Obviously, this is really important, but I just think we don't understand exactly when and where and how we're going to utilize this drug and the information that we even have about LP little a. I mean, we know the basics. We understand that it's causing something, but we don't really have an algorithm to figure out how to use this yet. So I think I am excited to see how this will fit in once we get closer to figuring out an algorithm and how we can really work this up. And I do think that this is something that's gonna, you know, it will be out in the next 5, 10 years. I think we will easily figure this out as we start using these agents and or as we have been testing for LP little a. So that's what I was thinking about it.
Yeah, I feel like we have more questions than answers.
Right, right. And I mean, I think I love the drug. It clearly works. It has really very little side effects. It even has a tiny reduction in LDL, but yeah, we don't really have answers yet to really figure out where it goes in the algorithm and where it goes and how it impacts our patients in the long term.
Yeah.
Yeah. So, I think that's it for today. Any other thoughts, guys?
No, I think that's it. We'll see how things progress with this study.
For sure. Okay, today's fun question is, what's your favorite beverage? Ankit, do you want to start?
I just like water, man. I'm not a soda. Not that type of guy. I just like
You
water.
really?
I'm pure.
Do you drink coffee?
No, not really. Rarely.
Oh my goodness. Okay.
Yeah.
Well, I don't know what to say about that. I guess you'll live longer than us, but I think
Bourann.
I have, I love Diet Coke. That's probably my favorite. Specifically Coke Zero, but Diet Coke is acceptable as well.
Why
This
not
is not an
Coke?
advertisement. It's
It's
just
not an advertisement, but I can't help it. And coffee, but I don't
yeah.
know if I'm allowed to pick two. What about you, Anisha?
I think I'm squarely in between both of you. I really do love water and I do really enjoy drinking it. And I think I really do love me a Diet Coke or a coffee. But I'd say I think between Diet Coke and coffee, I would pick coffee, but I would pick not just black coffee. I would like a cappuccino.
Oh, yeah, yeah, no, no. I mean like
If
a
I only had cappuccino and water for the rest of my life, I think I'd be okay.
Why not Coke?
For Bourann, is that a question for
Yeah,
Bourann?
yeah, why
No,
Diet?
I don't like how Coke tastes.
You're
It's
trying to be like
cheesy.
fake health.
It's not. Oh my goodness. It's not gonna get it. Okay, artificial sweetener tastes good. I don't know what to tell you. Not an
Artificial.
endorsement of it from a health perspective, but it tastes good and I could drink it like all day, but like a Coke, it's like too sweet to drink a lot of it.
Look, it's all about balance.
All
All right,
right.
thanks everyone.
Thank you guys.